So now we're going to work on doing long. Same exact motions that you use to find your proximate and distal trans, you're going to do the same to get to your long images. So following back down and turning until we have it lengthened out. So losing contact on him, I'm going to come out now and angle back in to try and get it. Turn your head slightly towards me. There we go. Don't forget to adjust your patient as need be. So the head turned all the way might not be what you need. You might need to have it slightly turned back towards you in order to avoid getting around all those muscles in the neck that can be difficult. Lengthen it out all the way from where it connects here, nice and open across the whole screen. So that's going to be long 2D. I do not want it pinched off here, opened all the way as far as you can see. If you can see all the way to the trunk, please show me that. Opened all the way, and no echoes, but I can see the walls still very clearly. Next step, add color. Should not be moving too far from where you're at all. Stay nice and steady. So I got some aliasing happening, which is common when you get closer to the heart and closer to those larger vessels, but we are going to bump the scale up a little bit. Try to avoid some of it. All right, so that's going to be your color. We're not bleeding out and over the vessels, filling from edge to edge on the box and edge to edge on my vessel. Next, we're going to do pulse wave. This needs to be parallel in your vessel, parallel with the walls. Use your steer, so not just the angle correct here, but you're going to use the steer as well to help get you to where you need to be, right in the center of that vessel. So this is touching the top here. So I'm going to need to bring my baseline down. This nice clear spectral window tells me that that gate is centered perfectly in the vessel. If this is not clear, you're getting too close to the walls and not getting a true velocity. So that needs to be centered for that to happen. Make sure you do your measurements. Make sure you put it in the package. That's going to be important when you calculate your ratio at the end, where you have to select which segment of the vessel's velocities that you're putting into the ratio, and that is on your protocol. So you'll do the peak systolic, peak diastolic, you'll remember from aorta, directly before the next peak. And you record that in your package. So we're going to do that for every segment of vessel. Try not to pick your probe up or move too far from where you're at. That's going to make it easier to follow the vessel. So we're just going to keep sliding until I get to about my midland mark here. So I just went back in trans to confirm. Decrease our depth, we don't need that much when we're here. Same exact rules apply. Lengthen from edge to edge. I can see my walls clear. TGC is not too dark above or below. I can see spine, I can see muscle, I can see skin tissue, but this is nice and clear, as well as the lining of the wall, the intimal lining. Those are all the things we want to see. Make this box just ever so slightly larger than our vessel. A nice angle is going to give me good color fill. The straighter this is, the harder it's going to be to fill edge to edge, and you're going to fiddle with that way too much. If you angle it, that is going to help your cause. You good? Sorry. That's going to help your color flow options here. So this is what we're going to want to see. Once again, edge to edge on box, edge to edge on wall. And your flow pattern should be very similar here as it was in the mid. So moving on to distal, you're going to keep sliding up. Now on him, it's nice and easy for me to get to distal and still keep that angle. If you are struggling to open it up all the way, heel toe the opposite direction. We're still sewing the distal into the bulb part here. And going to slide down just a little bit because I'm just isolating the distal. Still need to be showing the bulb so that I know where you're at. That proves to me you're not just still in some segment of the mid. So once again, same 2D rules apply. Opened all the way across, walls and gains are correct. Now, our box. The box needs to go in the direction your vessel is flowing. If I continued on this angle, my box is fine because we are angled with the direction of the vessel. If I angle my vessel this way, I will need to flip my box. So use your steer to angle this direction. And once again, all the same rules apply. Now you'll notice I'm not feeling too great right here, but I'm getting into the bulb. So I'm going to lower my scale just a smidge. And now I'm going to feel a little bit better. But my focus is the distal. So that's what I'm going to look at here. Same rules apply. So again, if my angle I can't get to it, I'm going to go to 60. That's 60. I can adjust by angling my probe, or I can steer. Once again, fine-tuning it so I can get the correct placement. Very similar flow pattern to the rest of the carotid. Now moving into the bulb. Bring my depth up, I don't need all that. So the bulb you're going to show opening in either the ICA or the ECA. I don't care, but it is a little bit more easily achieved opening into the ICA. I want to see a little distal, I want to see bulb, I want to see this vessel that it goes into open all the way through. You're going to put color on once again because we are changing directions and we're going from a wider vessel to two narrower vessels. We're going to have a little bit change in the flow pattern. So if you see some blue happening within the bulb, that's fine. That's normal. If you don't have any, that's also fine too. You see that little bit of blue? That would be fine. That's also fine. Now your flow pattern in the bulb is going to be a little bit different as well, because once again we're going from a higher velocity into two separate vessels, changing our directions. So your bulb, you want to be lined up with whatever vessel you're deciding to open into. You can open into the ECA and you can take it here. You can open into the ICA. That is easier achieved than this because now you have to change the angle you're coming at here. It's just easier if you open into the ICA. Center. You can steer while you're acquiring your pulse wave. Now some of the bulb velocities may be a little bit turbulent. That's to be expected. This velocity is also normal in the bulb. Moving on from the bulb, you're going to go into either ICA or ECA. I don't know which one's on your protocol first, but I'm going to go with the easier one that we're getting proximate and distal on, and that's going to be your ICA. So ICA feeds the brain, angle towards the base of the skull to get the ICA. ECA feeds the face, angle towards the face to get ECA. So slight angle towards his jawline brings in the ECA, slight angle out towards the base of the skull or the earlobe gives me the ICA. So again with our 2D, same rules apply. Let me see all those edges nice and clear. We're going to do color. As you go deeper into these vessels, you're going to need to adjust your scale and your gain because you're increasing the amount of strength that's needed to get to those deeper structures. So your ICA is going to be a low resistive flow pattern because we're feeding the brain. We do not want resistance to our flow pattern in the brain. So a high resistance flow is going to have a higher diastolic. So that's going to tell you the difference between your ICA and your ECA as long as all things are normal otherwise. You have any sort of pathologies that can change these flow patterns, but your velocity needs to be higher resistive whenever you're in the ICA. And as an example, we're going to go to the ECA and you're going to see the difference in that flow pattern. So this is going to be a high resistive flow pattern. See the difference now. Your systolic flow is a much higher, sharper peak. It's not as low and slow to peak, it's much sharper and quick, so your acceleration time is very fast. Your deceleration time and your diastolic flow is also much lower. This is a high resistive flow pattern that the ECA has. So going back to our ICA, we're going to get our mid Dopplers and you're sliding up the neck. If you need to come out more lateral and angle in, that will clear up your image and have a little bit more success on the approach as you go deeper in the structures. So that's going to be mid. It's also going to be a little bit trickier to get your gains clear, but it is achievable. Just make sure that you make the right adjustments. So here again, same rules apply. Come back, color. We're going to come down here. That is our mid. You can make your box a little smaller here to help with your flow pattern for your color. But that's your mid, and here again, low flow, low resistance flow. And keep sliding. And when you reach here, where you get this big shadow, and you're probably either right behind the ear or right on the earlobe, this is as distal as you can go because we're hitting base of the skull. The ICA is going to insert into the base of the skull and go up into the brain structure. So this is your distal. Your color will help you determine that too. If you get to where you can't really see all that gray, we're going to come back, color on. Perfect example. If you get lost, go back to home base. Find somewhere familiar and then follow it. So we're going to follow. And here we go. Now we are in the distal. And this is as distal as we're going to be able to see on this particular vision. So here you'll do some adjustments to bring in, oh, too much. Bring in your color. So we're going to bring scale down, we're going to bring gain up, and that's going to be less fill than you'll get in the other parts probably just because we're going deeper, but that's acceptable. And again, low resistant flow. So that's all of our ICA all the way into the distal. So remember, adjust the head back and forth, chin up or down, and then you're coming very lateral and coming on the outside of that sternocleidomastoid muscle that runs down the neck. Come on the other side of that muscle and run up that muscle on the back side, and that's where your vessel is going to be found if you can't do it from the more straightforward side here. So all the vessels in every patient are going to be a little bit different. All right, so now let's do ECA. Back to bulb, where we're familiar. We know that that is ICA angling out, so we're going to angle in towards the head. All we need is prox, but I do want to keep it nice and lengthened out as best you can. Focal zone. So here we go. This is going to be prox. So bulb, prox ECA, lengthen out as much of it as you can. Best thing to remember about doing this vascular stuff is to move real slow and steady. So now I'm going to bring my adjustments back. Bring my gain down and my scale back up. Now I've got this nice pretty flow here and pulsate. There's your high resisted flow. And we're making sure we got a good spectral window again, and that our waveform isn't touching the top here. All the same rules from aorta apply. Don't have that baseline too low, and make sure that there's nothing dipping below that we're not showing. All right, so that is ECA. We're gonna go to vertebrals now. Vertebrals, the best method I have is coming back to your prox or mid CCA, and then angling out on the neck. More forward, more medial on the neck, and we're seeing spine. So I'm going to angle, keep going with my angle, see if I can see the blood vessels there. And that's going to be vertebral. So what it tells me is it's in between the vertebral bodies. So this like circular shadow here and here, that tells me that vessel is running in between the vertebrae. So that is correct. There we go. That's even better. So this is more talks down here, I just slid up like 1 or 2 more vertebrae, and that is gorgeous. So I'm gonna go with that. Steer. Again, this is lower velocity vessel, so we're gonna need to bring that down on our scale. That's gonna be color, and once again, vessels that go to our brain don't want to be high resistive, so you're gonna see a lower velocity, lower resistive flow pattern here. So this probably needs to come down some more because our velocity is not that high. So I would bring my scale down some, but that's the waveform pattern that you'll see. And that's gonna be all of your long carotid images. And same for the left side. That's it.